Testing 1 2, testing 1 2. Okay. You can hear me okay? Can anybody hear me okay? Hello, can anybody hear me? Okay. Can anybody hear me? Hello? Oh, there's Andy. Okay, I know he'll talk to me. Hello, hello, hello. Hello, Andrea.
Hello, John.
Hey, how you doing?
Fine, fine, fine. How are you?
You can hear me okay?
Yes, yes, yes.
Yeah, yeah. How you been?
Been a tough period, let's say like this.
Yeah, yeah. But things are getting better in that part of the world, right?
Yeah, they're getting better, and we just opened a little bit in the last week. We'll
Okay.
see. We'll see for the next week if the cases are actually getting a little better. I don't know.
Yeah.
What about you there?
There it's pretty well locked down. Things are pretty tight, actually. Where people wearing masks everywhere, and there's no restrictions. You can still walk around, but is that what it's like there? Pretty well, you can walk around, and or is it pretty locked down still?
Until last week, it was total lockdown,
Oh,
and now you can go, but only to visit, only to go to work for
oh,
some
okay.
people, not everybody. Like, and you can visit relatives actually.
Oh, okay. So it's
Of
perhaps.
course, there are many people around, more people than before around, but I think everyone is more responsible now.
Yeah,
They figured out that it's a difficult disease, so uh, there are no reckless people. I mean,
yeah. I was surprised at how responsible people are here in
yes,
this
me too.
area. I thought
Me too.
no one would listen.
No, but we had many casualties, so I think people
Yeah.
understood that.
Once you see a refrigerated truck, the message kind of gets through, I think.
Mm,
Uh,
yes, of
so,
course.
anyways, okay, we don't start for like 15 minutes, so I got to do some stuff. Okay.
It's okay.
Hey, you remember how to screen share, right?
Yes.
You want to practice? You want to make sure?
But I think just like this, I can just share the screen like this.
Yeah. Okay.
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 Good.
You want to go to your PowerPoint? Or did you?
Wait a second.
Yeah.
I
Do
can
you
just
have any
open it up.
videos in your PowerPoint?
No.
Okay.
Only pictures. So. Uh, 1 second. I can just share this.
You know, I've never seen that word before. The title of your talk. Oh, that's the title of your talk, spinal infections?
Mm-hmm.
Okay, okay.
Okay.
Very good,
Now
very good, works
it's
good.
working. Okay.
Okay, you're all set.
Okay.
Oh,
Okay.
you've done this a few times before, right?
Yes, sometimes.
It's getting easier. For me, it's easier to use. It's getting easier, better and better.
Yeah. Also, I had to do this kind of presentation for my professor in the next few days. So
Yeah,
it was
it's
difficult.
exploding. The use of it is exploding.
Yes.
I don't have to explain anymore what it is.
Yes.
Zoom, what's that? But now it's, yeah, I'm zooming
No,
somebody.
yeah. Everyone is doing Zoom right now.
Yeah, for sure. Okay, I'll be back.
Okay.
Greetings, everybody, including Lucindo. Can you hear me, Lucindo? Can you hear me? Perhaps he stepped away. See how professional we're getting, Andrea? Starting in a few minutes. It's beginning to resemble TV with props that fall down. It's got a lot of Scotch tape. Here's Daddy and Dung from Nigeria, both guys from Nigeria. One's a neurosurgeon, one's a resident, neurosurgical resident. Hello, Daddy K, good day. Just getting settled. Now this is how professional we're getting. I'm going to change my background to like not starting in this regular. Now, how professional is that? Can I have some applause? I mean, can you guys don't have to, you can unmute and applaud. Hey, all right, someone's listening. We're getting very professional here. We're gonna start in 2 minutes, Andre, okay?
Okay, John.
It's a little bit different, Andrea, now. There are a lot of more people coming. And I don't have to tell anybody about muting. I think everyone's muted now. But of course, you know, after we'll take it as it goes. You can text questions in the chat anytime, especially if you don't have a good connection. If you have a good connection, you can wait to talk to Andrea face to face and give her your question. If you have video capability, if you don't, that's fine. You can just, you don't have to turn your video on. Okay, Ipe's coming. Okay. Okay, Andre, you ready?
Yes.
Okay.
Yes, I'm ready.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It's Dr. John Bennett, home of Neurosurgical TV. We have the pleasure of having Andrea Gerosa, a neurosurgeon from Parma, Italy. He's going to be talking to us this morning about spinal infections. Okay, Andrea, thank you for coming, and it's all yours.
Thank you, John. Thanks, everybody. Hello, everyone.
Very little. I'm trying to get myself off the screen. Hold on, Andrea. We're not too professional here. I gotta unpin myself. Okay. Okay, there is the screen shorts. Go ahead.
Okay. So we can talk about spinal infections. First, a little bit on definition of spinal infections. So there's a bit of confusion. We have discitis and spondylodiscitis, which is inflammation or infection of the disc, and osteomyelitis or spondylitis. So when the infection spreads towards the bone, and usually both of these terminologies are used because the infection usually spreads from the disc to the bones. So there's an involvement of both the structures. Of course, we have discitis, spondylitis, spondylodiscitis, paraspinal infections, so infections of the muscles and the tissues of the near the column, and we have, for example, psoas abscess, and we have spinal abscesses like intramedullary, subdural, or epidural. Spinal infections such as spondylodiscitis is an ancient disease, and we have found skeletons that are very ancient with changes consistent with tuberculosis. And in fact, the first description of Pott's disease was given in 1779. So a little bit on the epidemiology. There is a bimodal peak with involvement below 20 years old population, and then 50 to 70 years old. The mortality is referred to 4%, and the incidence has increased in the last years, partly because we have diagnoses that are more reliable, and also because there's an aging of the population, and we have many more factors that are important in the spine. For example, we have previous spine surgery, and actually 1/3 of all the spinal infection is related to previous surgery. Of course, diabetes is very important, and other conditions are, of course, immunodepression and intravenous drug use. So for the etiology, we have pyogenous infection that are mainly caused by bacteria. In the last century, tuberculosis was the main spinal infection, but nowadays Staphylococcus aureus took over with an incidence reported up to 80% of all causes of spinal infection. Then we have enterobacteria with E. coli, with Klebsiella, and all the gram-negative agents. And then we have other classes like Pseudomonas, which is associated with drug abuse and urinary tract infection. We have the Staphylococcus epidermidis, which is related to previous surgeries and implants, and streptococci, which is associated with endocarditis. In the literature, we can find that the polymicrobial infections are uncommon, and the most frequent reported data is less than 10%. Actually, in recent days, more studies are coming where two or more than two organisms are isolated. So probably there's an under recognition of multiple agents in most of the old series, or old paper series. Then we have the granulomatous infection. So we have tuberculosis and fungi. The skeletal tuberculosis is associated strongly with HIV infection, and while fungal infections such as Aspergillus, Candida, and Cryptococcus are associated with immunodepression conditions. Parasitic infections are very rare, and one of the main causes is Echinococcus, which is a parasite transmitted by farm animals. And it's a zoonosis such as brucellosis. Brucellosis is caused by a bacteria, Brucella, and usually is transmitted by farm animals and consumption of milk and cheese. The brucellosis is an uncommon diagnosis in the spinal infection, and has some specific characteristics, like you can see in this MRI. Usually there is a diffuse involvement of the bone without deformity and without involvement of the posterior elements, without kyphosis. The diagnosis of brucellosis is mainly serological. There is an appropriate treatment, medical treatment, and I already said that it's an uncommon cause of spondylodiscitis, but can be taken into account when there is some specific clinical issues. For fungi, we already said that are more common in immunocompromised patients. Usually, the diagnosis is delayed, and so the medical therapy is not always useful, and the surgical approach can be helpful to divide the tissues.
Excuse me, Andrea. Andrea, we're having trouble with your audio. Can you flip it on and off? Kind of play with your audio a little bit. It's kind of going in and out. Do you know what I mean?
I don't hear very well. I can't hear very well.
Yeah, we can't hear you very well. Let's just play with it a little bit. Let's try to fix it. Yeah, let's try to fix it. It's certainly worth an effort.
John?
Yes, I can hear you. It's still broken up. Go ahead. Say it again. Talk again.
I hear you very.
Yeah, it's not very good, actually. You may have to go back to your headphones or to your hearing device. We'll get it. May take a minute or two. Because at the beginning it was fine.
Wait. I'll try with the headphones.
Yeah, try that again. Okay. Go ahead, talk. Go ahead, Andrea. No, can't hear you. No, can't hear. No.
Now I can hear you well. I don't know.
Is that better? Can people hear? Can people hear okay?
It's
Go ahead.
not.
Give it a try, Andrea. Go ahead. Try it.
Wait, okay. Let me try again. I'll try to disconnect and come back again.
Well, yeah, you could leave and come back, reboot and come back. Do you know what I mean, Andrea? We can take a minute. Let me tell. Sorry, folks, but these things happen. That's it. Okay, good, good. I think we have the first thing to try is reboot with anything wrong with the computer. And then just keep your fingers crossed. Unless anybody has any input. We have a team of computer experts here, so. He'll be back. Just hang in there in a second. Because he's done these before. Okay, I think he's back. Okay, you're going to try it again? Can you hear me okay? You're connecting now. Okay, let me unmute you there. Go ahead, can you go ahead, Andrea?
I'm trying with
That's good. The sound is great.
Okay, I tried with the phone now, and I can try with the presentation here.
Yeah, yeah.
It's. I hope this will. Okay, I'll screen share like.
Okay,
this.
good. Is this the first time?
Yes.
That's right. Good. We'll have patience. Ike does this all the time.
Okay. Now can you see the?
No, not yet. Not yet.
Yeah.
Yeah, you click the share button. I don't know if you have the share button there.
Yes, I have share content.
Yeah, and then it looks for your PowerPoint. Then you can look for your PowerPoint and share it.
Zoom. Okay, now can you see?
Yes, you're sharing it now. Okay, just take us where you want to take us.
Okay, and you
Very
can
good,
see.
very good, excellent, excellent.
Okay, let's
All
start
right.
with. I'm
Excellent,
sorry.
excellent.
Okay, I don't know what happened before, but let's move on. Tuberculosis. Tuberculosis is a common case of spondylodiscitis, and
it's very significant. But some people may have this orball presentation, the one on the top that Dr. Srivastava was referring to, has a significant.
Okay, I'm sorry, but there was some noise. We have many ways. We have three main ways for the infections to spread in in the spine, we have a contiguous spread from infected tissues, for example. We have the hematogenous spread, and we have a direct invasion, for example, with pain medication infiltration and stuff like that. So we have a local spread of the infection. For example, some things that to take in account are in the cervical spine. If the prevertebral fascia is penetrated, there's a risk of an involvement of the mediastinum, and that can be very, very risky for the patient. And we already mentioned the psoas abscess in the lumbar spine, for example. And of course, you can also have an involvement of the spinal canal with abscess, with epidural and subdural abscesses. The hematogenous spread happens because we have a plexus, a venous plexus, the Batson's plexus, which is valveless and seems to be involved in the spreading of microorganisms and also for tumors. The hematogenous spreading is different in adults and in children. In adults, usually there's a septic thrombus that usually cause the end plates of the vertebra to be destroyed, and this way the nutrition of the disc is impeded. So we have the infection that spreads from the bone, from the end plates to the disc. In children, usually is the opposite, because inside the vertebrae of the children, there are many anastomosis, vascular anastomosis. So usually we have the bacteria that locates inside the disc. The disc degenerates, is infected, and then the infection spreads towards the end plates. For the clinical presentation, the most common symptoms is a non-specific regional pain. Of course, the pain is worse standing and is always present. Then usually with pyogenous infection, we have fever in half of patients. Is much less common in tuberculosis. We can have neurological involvement for the epidural abscess, for the compression of roots or spinal cord, or for spinal instability or fractures, and we can have deformity. In children, non-specific symptoms are far more common, while fever and neurological involvement are very rare. And the most common symptom is usually a loss of lumbar lordosis for the pain. So for the diagnosis of spinal infection, we have the laboratory findings. ESR and CRP are not very sensitive, but may be used for monitoring the response to the therapy of the infection. Usually we have leukocytosis with and another very important tool is blood culture. Then we have imaging. I don't know if you can see well the imaging here, but we have a plain X-ray, which is very low specificity, but can see the involvement of the bone. As CT scan, can see usually the necrosis and the deformity and the involvement of the end plates. Then we have the MRI, which is very, very useful for diagnosis. Spondylodiscitis is usually hypointense in T1 sequences. This is a contrast enhancement MRI, and you can see the peripheral enhancement in around the abscess and the vertebral bodies that are involved. And of course, in T2 and STEER sequences, there's hyper intensity because of the liquid, of the fluid collection of the infection. But it's not that easy because, for example, we have here some differential diagnosis. This, for example, is very common is an MRI. This is less common, but could be a spinal infection. Do you have any idea? Anybody has any idea of what, for example, the images on the left are?
Go ahead, floor's open. Anybody can answer.
Okay, people
That's
are
okay.
shy.
Yeah. Go ahead.
Okay, this is
Degenerative disease.
on the
Go
left
ahead.
side.
Go ahead.
Yeah, degenerative spine disease.
Yes, of course. But actually, it's not always that easy to differentiate from a common degenerative spine disease and a spinal infection. Of course, as the disease progresses and as the changes are more and more towards the deformity, is easier. But in the beginning of the clinical presentation, it's not always that easy. So we have more advanced imaging, such as PET and such as nuclear medicine with white blood, with marked white blood cells. For example, PET imaging is very useful in a fixed spondylodiscitis when you have screws and implants, because it can monitor how the infection is going and how the infection is healing. Because of course, these two kind of imaging rely on the metabolic activation of the tissues involved, and of course is less used for differentiate from tumors, for example. The final diagnosis usually is made with harvesting of tissue samples, and for this we have the biopsy. We have, sorry, maybe this is better. We have biopsy. The CT-guided biopsy is very useful, and it depends on the expertise of radiologists and the numbers of samples sent. And when CT-guided biopsy fails, open biopsy can identify the etiological agent. We also have different kind of pattern in pyogenous and tubercular spinal infection. As you can see here, these are the most common patterns of tubercular spine. We have the paradiscal, the central, that can mimic a tumor. The anterior and posterior are more rare. And also with we can differentiate pyogenic and tubercular infection also based on the clinical history. So usually pyogenic has a more acute onset. It's more common in lumbar spine, while tubercular is more common in thoracic spine, and mostly it involves a single level. Here you can see a diagnostic algorithm that we actually talked about right now, and the etiological diagnosis, which is useful because one thing that you have to do when treating a spinal infection is treat the patient with broad spectrum antibiotics and switch them to targeted therapy as soon as possible. So we are surgeons mainly. So what to do with when you are referred to evaluate spondylodiscitis? Many cases can be managed with a conservative approach. When there's no neurological deficit, when there's no instability and no intractable pain, or when the patient is at high surgical risk, or this is controversial, but in the literature there are many papers that actually state that minor neurological deficits, such as mild and stable paresis, or only sensation symptoms, can have good result only with the conservative management that consists in immobilization with bed rest, usually with braces or collars. Of course, the antibiotics for pyogenic, we have an empirical broad spectrum therapy. And there's no regimen that has shown to be superior to another one. Usually there's an agent that covers the MRSA and one for the gram negative. And of course, as we were saying before, must be switched to targeted therapy once you have a precise etiological diagnosis. The duration usually is of 3 to 8 weeks. Actually, this is one of the things that in literature are more clear, and there's a strong evidence that after 6 weeks, it can be switched to oral therapy once you exclude endocarditis. For tuberculosis, we have the 4 drugs that are used for lung tuberculosis as well. But the duration of this therapy is longer, usually more than 1 year, to eradicate the infection. So for the surgical management, of course, it's easy. When we have neurological deficits, we do the surgery, we do the decompression, we do the usually we do the fusion of the spinal during the spinal surgery, and that's easy. But there are more things to take into account. For example, we have the instability. We have the untreatable pain, and of course we have the failure of the conservative management. In the literature, about 15% of the antibiotic therapy cannot control the infection, and the patient worsen. So take this into account when you are called to evaluate spondylodiscitis. The surgical strategies may be different, but the bases are all the same. So we have decompression of the neural elements. We have aggressive tissue debridement and drainage of the abscess. Sample harvesting for etiological diagnosis. And of course, when needed, we have the stabilization, the fusion of the vertebral segments. This is a simple how to say in diagram for the indications of surgery. And we have different approaches. Usually for cervical tuberculosis, for cervical spondylodiscitis, we can have anterior or posterior approach. The posterior approach usually is chosen when we have an abscess to drain, and with less involvement of the vertebral body. While for the anterior approach, we have the involvement of multiple vertebral segments. It's possible to use cages, but you have to be very aggressive with your surgical debridement. You have to see bleeding cancellous bone before stopping and placing the cage, because otherwise there's a high risk of non-fusion and of graft displacement. And usually, depending on your experience, depending on the patient, it can be completed with a posterior instrumentation if needed. It's not always needed to complete with a posterior approach, but sometimes even in a second stage surgery, if for example you see kyphosis, progressive kyphosis of the neck. For the thoracolumbar approach, there's the Hong Kong technique that is very well described, and we have a lot of papers and a lot of literature about this. It's always the same thing, but they describe a debridement from an anterior approach, reaching the dura and the bleeding bone up and down, and then placing a cage. And sometimes, and usually they place also posterior screws, of course. For the lumbar approach, usually a posterior surgery is sufficient, and early surgery is usually associated with a better functional outcome and less pain. I wanted to talk to you about this thing about implants and infection, because in my early experience, I came in touch with infectious disease medical doctors, and they are very, very against usually placing screws, placing implants, placing allografts inside an infection. And so in the last years, I went and searched the literature, and actually you can see from these papers that, for example, the anterior interbody fusion with cage followed by posterior pedicles can be effective, and they compare the cage with the iliac bone strut, and actually cage performs better than the bone of the patient. And for the posterior with the cages, this paper says that they achieve a more rapid fusion and they have few postoperative complications. But of course, many medical doctors, many infectious disease medical doctors, they are concerned about this, about the biofilm that many bacteria can produce, and they attach very firmly to screws and to materials. This is true, but it's true for older implants. For example, here we have this paper. This is from 1993, as you can see, and they found that there were no recurrence of infection in instrumentated spinal tuberculosis. Again, this is from 2009. They had 2 recurrences, but one with allograft and the other with autograft. So they found no increased rate of recurrence. Sorry, and here again we have 2016. The use of PEAK correlate and reinforce the previously published literature. So when you speak with your medical doctors, and usually at least for us, spondylodiscitis are referred to us from infectious disease doctors. They treat the patient. They treated the patient for a long period, and then they refer to the surgeon, for example, just for the positioning of a brace, of a collar. But actually, you can convince them that in some cases surgery is actually better than the conservative treatment, and there is no, with the new materials, with the new cages, with everything, you don't have a risk for the bacteria to attach to the cages, to the implants. And actually the main point of stabilization of the spine is actually to avoid prolonged bed rest, which is something that, for example, in elderly patient can be as harmful as an intervention, as a surgical intervention. And usually the results of aggressive surgical technique with stabilization are good, and they provide a less favorable environment for the bacteria, for the microorganisms usually. A few words about intramedullary abscess. These are very, very rare. Usually there's a spinal cord pathology present, for example, in children with dermal sinus. And of course, L drainage with antibiotic is the treatment. The subdural empyema, as well, very rare condition, very urgent to treat. The diagnosis is, of course, with the MRI, with decompression and antibiotics as primary treatment. And the spinal epidural abscess, here we have a secondary. We talked about this, is associated with surgical procedures or injection, and the primary spinal epidural abscess, which is associated with intravenous drug uses and the UTI usually. Usually you can treat this with the surgical decompression, except for extremely long abscesses, or when there is complete paralysis for more than 72 hours. Usually the results are very poor. Also, we have paraspinal abscesses. These kind of abscesses usually are treated with antibiotics, and can be treated surgically if you plan an intervention, or they can be drained with the CT-guided approach. And concluding, the mortality of spinal infection has dropped under 5%, but in 1/3 of patients there is a motor involvements residual. So the early mortality from spinal infection is very high, and now with the surgical treatment and the correct antibiotic therapy, we took it under 5%. And for the take-home messages, so I hope I was clear about when to perform surgery. I told you when we have a neurological deficit is easy. It's easy to justify a surgical intervention, but there is more about this. So always evaluate spinal stability and the efficacy of conservative therapy. And we already told you this, 15% of conservative management. Early surgery is associated with slightly better result. And how to operate. So there are only 2 randomized clinical trials, this one and this other one, and they both say that the anterior approach is slightly superior to the posterior approach. I don't know if this is still true. There are many less invasive surgical techniques, such as minimally invasive techniques like percutaneous techniques that are not being investigated. And this is why, for example, I put this picture and this paper. This is something that it's a description of the surgical technique that was very interesting for me. They performed a posterior approach, as you can see. They decompressed the spine, they achieved the spinal fusion, and they performed a posterior discectomy. And then they placed 1 tube for inside the disc for irrigation with antibiotics, as you can read in the postoperative procedure, and 2 tubes for collecting the fluid, the fluid, and they had a very good results. If you want to read this paper, they had very good results, and actually with the posterior approach, the instrumentation, and a minimally invasive debridement, we can call it like this. So you don't have to do an anterior approach, which is less familiar for usually for neurosurgeons, but this kind of approach, this kind of ideas, minimal invasive and less invasive procedures, I think they should be evaluated. They should be tried to achieve better results in this kind of spinal infection. And I'm finished.
Okay, great. Thank you very much, Andrea. That's a testament to your resourcefulness, being able to present that on your iPhone.
Yes.
You did it completely on the iPhone, right? Audio and...
I don't know. Sorry, everyone. I don't know what happened before. I had some issue with my tablet, it seems.
Well, it worked. It worked. It was great. Okay, so it's open now for questions or comments. Don't let me drown here.
Uh-oh. My goodness.
Usually Daddy steps in here to rescue me. Even Daddy's not coming in. Man, oh man.
Okay. Yeah, hello.
Oh, there you go, Doug. Okay,
Leonard.
how you doing?
I'm fine, Dr. Leonard. Thank you. Thank you very much, sir, for the presentation. Yes, please, I have 2 questions. Just trying to find out how your practice, you are able to achieve the effective delivery of IV antibiotics for 6 weeks in patients who do not have any other indication for in-hospital admission. In your practice, how do you go about it? Those you do not need to admit for any other indication and need to be on antibiotics for the 6 weeks duration you mentioned. Do they come to the hospital every week or every day rather to get their antibiotics, or do you have a system which is able to deliver those to them at home? I'm asking that question because in our environment here in Nigeria, sometimes it's a challenge. Some of our patients live in the interior, in villages that are not where they aren't easily accessible. So it becomes a challenge for us. Sometimes we have to admit them for weeks just to make sure they get those IV antibiotics before we switch over to the oral form. How are you able to achieve that in your setting? And secondly, I don't know if you got the question.
I think I got it. You're asking what kind of strategy we use for delivering the intravenous drugs?
Yes, for those who do not need to remain on admission for any other indication. Patients who are ambulant, for instance, only need to receive IV antibiotics for 6 weeks. What strategy do you employ in ensuring they get those for the entire duration?
Actually, usually in our common practice, people with spondylodiscitis are admitted in the hospital and they stay there for weeks. For usually at least 6 weeks, sometimes more. Usually we use a central line, some kind of central line. It depends on the patient. It depends on what you have available. I don't know about alternative strategies for settings like yours when the patient cannot be admitted. It could be interesting to see if the oral drugs are at least at some point useful, even with a shorter period of intravenous drugs, and then switch to orals, of course, after excluding a heart involvement. The literature is very strong about the 6 weeks of intravenous therapy, not more than 6 weeks because it's not useful. They tried 12 weeks of intravenous drugs, but it didn't give any advantage. So I don't know. Maybe you could try with the oral drugs and see if you have a positive result.
Yes. Okay, thank you. I think your answer is quite helpful. Yeah, we do that sometimes. In a few cases, we switch the oral to the oral form before the 6 weeks when we really do not have a choice. Maybe the patient has some financial constraints in certain instances, or for some other reason, the patient has to leave the hospital. So sometimes we have to switch to the oral form a bit earlier than the 6 weeks. And in many cases, we've been able to get results. I just wanted to know if in your case, you sometimes discharge patients home and you have maybe family physicians deliver the medication at home and all.
But do you think the results are good, are at least comparable with the intravenous prolonged therapy, or not?
Yes, I think, well, it's difficult without giving you specific figures, but I think there have been cases that we have managed that way after, say, 4 weeks on IV and following up with C-reactive protein, for instance, and ensuring that the values are going down and that the infection is being controlled. And then switching to oral because we do not have a choice, because we are constrained to do that. And yes, I think we have gotten good results in most of those instances. But usually that would be because the infection is already quite controlled, as evidenced by the biochemical parameters. So switching to oral maybe a week or two before the 6 weeks, we are still able to get away with it, I would say.
Okay, okay. Has he answered the question? Okay, I believe Uday Gupta has a question. Go ahead, Uday.
How do you measure the instability? Is it through the Cobb's angle or any other measurement you take for measuring the instability at levels of spine?
Did you hear it okay, Andrea?
I think I got it. You're asking about how to measure the
John.
Instability.
Go ahead, Big Daddy.
Hello, John. Can you hear me?
Yeah, go ahead. Go ahead. We
Okay,
have a-
I'm saying.
I said
Sorry, you're breaking up, Big Daddy.
I'm here, John. I'm here, John.
Okay, go ahead, Big Daddy.
Okay, so I'm asking, very nice presentation, and I'm asking about his experience with brucellosis.
Brucellosis. Actually, I've never seen a case of brucellosis. It's very rare. I've studied that it's more common in the Mediterranean area, and actually Italy is inside the Mediterranean area. But I don't think I think I don't know anyone in the neurosurgical field in Italy that has managed a brucellosis case. It's very rare in my country. It's I personally I've never seen one case like that.
You know, it's like lupus. You study a lot in medical school, but you never see it. Okay, Uday Gupta had a question. We kind of cut him off. Go ahead, Uday. Go with your question again.
how do you measure the instability? Is it through Cobb's angle or any other measurement you use? And what is the use of traction? Any use of traction in tubercular spine?
I don't know if you got that. You got that question? You want to repeat it again, please?
No, I got the. How do you measure the spinal instability?
Yeah, is it through Cobb's angle or any other measurement you use?
Well, for again, in my country, we don't have many cases of severe kyphosis of, for example, for tubercular involvement. It was more common a few years ago. Now, usually, it's rare. It's not common to treat very, very high deformity, or at least they are referred to some very, very how do you say, very specialized centers. Usually, we just measure and evaluate the involvement of the three columns, so anterior, medium, and posterior, and you can usually cervical spine is done anteriorly, thoracic and the lumbar spine are done posteriorly, with a few exceptions. Usually, you can put cages in the thoracic and then lumbar spine when you want to achieve a better stability, but and you can rely on the Cobb's angle for more severe.
Any role of traction?
It's not very common in
Traction? Any?
What?
Go ahead.
Any role of traction in treatment?
Any role of traction?
Like
no, for
traction.
No, actually, for traction, usually don't do it in the spinal infection. Someone uses that for fractures, but it's not very common actually, and I've never seen traction.
Okay, let's move on to the next question from Danis Sartika. He says, which one do you choose between giving pharmacotherapy drugs and surgery if you find the patient with spondylodiscitis TB? Should we, through the intensive drug TB therapy, at least 2 months and continue with surgery?
Actually, one thing doesn't exclude the other one. So, of course, you do the antibiotics. That is not questionable. Surgery is you have to evaluate for tuberculosis if there's instability, if there's deformity. It depends. But of course, antibiotics is the main treatment in tuberculosis and in pyogenic spine, always. Of course, I think we are surgeons here, and we need to understand when to operate and when not to operate. But the antibiotics is the main treatment. I don't know if I answered the question, but
I hope so. Okay, Garakai, do you want to ask the question, Garakai or Saeed?
Yes, I would like to ask a question, please. Yes. Yeah, thanks very much for the good presentation. What I want to know is pre-operatively, before the operation, is there a minimum period for either TB or a pyogenic infection? Is there a minimum period that you have to give antibiotics in order to reduce infection of the implants? Did you get my question?
Did you get that, Andrea?
There's a minimum period of antibiotics?
Of giving antibiotics so that you prevent infection of the implants, of the instruments. So before, yes.
Actually, I haven't found anything like that in the literature, but it's very clear in the last 20 years of literature that with the new titanium implants, with new cages, the rates of reinfection, the rates of colonization of these kind of materials is very, very, very small. So, of course, when you do surgery, usually the patient is under antibiotics for at least weeks, usually. And you proceed with antibiotics for other weeks, at least 1, 2, 3 weeks again. So I don't think it's a real concern. At least spondylodiscitis rarely present itself with an acute neurological deficit, at least in my experience. So you have time to do the diagnosis, to do a broad spectrum therapy. Usually we don't have any problems about that. And the literature, I haven't found anything specific like this in the literature. Maybe there is, but I haven't found it.
Very good. Very good. Garakai, where are you from?
I'm from Zimbabwe.
Oh, welcome.
Thank you very much. Thanks very much for the good presentation.
Okay, I think we have a question from Saeed. Are you there, Saeed?
Yes.
Go ahead, Saeed.
Yes. Hello, everyone.
Hello.
Very nice presentation. Thank you. Do you have some multifocal spinal tuberculosis in your series, and how did you manage those patients?
Multifocal, I've
Yes.
seen one case, but it's not very common for us to have tuberculosis, and to have
Yes.
multifocal is even less common. I've seen one case, and we managed to avoid surgery at all. He had like C6 involvement, if I remember correctly, and a mid-thoracic spine, and we were thinking about fixating at least the thoracic spine, because he was going towards the ekyphotic angle, but he was not treated, because he was I don't remember very well, but he was a very young guy, just came from North Africa, I don't remember, and once he was treated for tuberculosis, once he started treatment, bed rest, and brace, actually the situation improved, and he didn't need the surgery. In a few months, the spine actually healed. He was very young, so maybe for an older guy, maybe we should have put some screws, but we managed him conservatively. Yeah, you understood.
Okay, thank you. I have also a comment about medical treatment and the duration of treatment. I think that 9 months, 1 year is sufficient for the majority of patients.
Yes.
Yes.
Usually 1 year, but in some cases they go on for 18 months, 24 months. It really depends. I agree. Usually with tuberculosis cases, 9 months, 1 year is sufficient. Not less than 9 months. Usually, if you stop at 6 months, you have a relapse.
Okay, sorry, I have a last question about, did you have some cases of craniovertebral junction tuberculosis?
No, never see. I hope I never see them.
Rarity of a rarity.
Okay, thank you very much.
Saeed, you're from Syria, correct?
No, from Morocco, from Marrakesh.
Oh, okay, welcome. Well,
Yes.
you've been here a few times before.
Okay, thank you.
Yeah, nice to see you again.
Yes.
Okay, more comments, questions from the panelists? Okay. Well, I'd like to thank you, Andrea, for taking the time out of your day. And
Thank you.
We'll
Thank you all very much. Thank you, John.
We'll get this edited and put it in your hands. And thanks a lot. And thanks all the panelists for coming. Adios.
Bye.
Okay, we stopped recording. We're off the air, but we're on YouTube.
Okay.
Hey, I was getting nervous there, Andrea.
I'm sorry, I don't know what happened, but
well, you rescued it, and you've never done it before, huh? You never presented on a smartphone before?
No.
Wow, under fire.
I don't know what happened, but it's okay. It's okay.
It worked out good. It worked out good. But that shows you can present from a darn smartphone. It's amazing.
No, I didn't know if I could do it, because I wasn't sure that there was the share screen option.
Yeah, it worked great. You can see it just as good as you can on a desktop. And the audio is great. When you use the smartphone audio, it was great.
I don't know what happened before, because
that was your laptop, right?
Yeah, it's not a very good laptop, but it's
yeah, it had to be that, because
it worked before.
Yeah, we were doing a conference in Africa, and the same thing happened. The presenter ran into a big trouble with the audio. So we, in order to rescue it, we said, well, just come into the webcast with your smartphone and just use the smartphone as an audio source, and it worked. The audio was perfect.
Yeah, but I hope it was good.
Yeah, it was good. We'll send it to you. Okay, everybody. Thank you very much, everybody.
Bye, everybody. Thanks, John.